online anesthesia video of this week. You can also participate in this program if you are interested. Just record your video presentation on Zoom platform and send to us in onlineanesthesia@gmail.com. For further rules and regulations, please visit our FB page online anesthesia. Let us watch this week's video.
Good morning. I'm Dr.P.Nagalakshmi, Professor and HOD, Department of Anaesthesia, Venkateshwara Medical College and Research Center, Puducherry. I'm immensely grateful and thankful to Professor Edward Johnson, sir, and his team of online anesthesia for giving me this opportunity to present a session on additives in neuraxial anesthesia. This is an important topic to the postgraduates and to the practitioners also, because in our day-to-day practice, we add a lot of additives or adjuvants to the local anesthetic mixture, be it bupivacaine or levobupivacaine or ropivacaine. It may be fentanyl, morphine, buprenorphine, clonidine, dexmedetomidine, and other drugs. So we should understand the mechanism of action of the additives, which we add in the neuraxial anesthesia, and their pharmacokinetic and pharmacodynamic properties to have a better understanding of the subject. So the learning objectives of this topic are: what do we define as additives or adjuncts, and the common neuraxial opioids and their implications when they cause, when we add in the neuraxial local anesthetics. Other common additives which added are alpha-2 agonists like clonidine or dexmedetomidine, NMDA receptor antagonists such as ketamine or magnesium, and other miscellaneous drugs which are commonly used in the clinical practice. So now coming on to the definition of additives or adjuvants. These additives or adjuvants to local anesthetics, they belong to a various category of drugs which act as various receptors other than that which are acted upon by the local anesthetics, that is a sodium channel, and they are clinically used to produce prolonged analgesia or to reduce the local anesthetic dose. They can act as a synergistic action with the local anesthetic. They also enhance the safety, quality, and efficacy of the blockade. So sometimes we add these additives to bring down the concentration of the local anesthetics, such as we add fentanyl, 0.5 ml of fentanyl to bupivacaine, so that we bring down the concentration from 0.5% to 0.375%. That is just to bring the concentration of the local anesthetic. Or sometimes we add any additive to increase the duration of action, either surgical anesthesia or post-operative analgesia. And most of these drugs are used off-label, and it can be used as a perivascular, perineural, or an intravascular usage also. Sometimes we use dexamethasone or dexmedetomidine as an IV drug, so that it increases the duration of action of the local anesthetic, which we give in the central neuraxis. So they can be broadly classified as opioid adjuvants or non-opioid adjuvants. Non-opioid adjuvants are usually alpha-2 agonist and NMDA antagonist, or other miscellaneous drugs such as midazolam and neostigmine. So now coming on to the main group of drugs which we commonly use in the neuraxis, that is the neuraxial opioids. So the mechanism of action of these neuraxial opioids is by a common molecular mechanism via a decrease in the excitability of the nerve cells. So by decreasing the excitability of the nerve cells, they inhibit the descending inhibitory pathways and decrease the pain transmission. So their molecular mechanism is they bind to the G protein coupled opioid receptors and inhibit the enzyme adenyl cyclase, activation of the potassium channels, and inhibition of the voltage dependent calcium channels. So they decrease the release of the excitated neurotransmitters like glutamate and substance P. And opioids administered in the neuraxial space, they provide analgesia in two different mechanisms, either by a spinal mechanism or a supraspinal effect. The spinal mechanism is the local action where the drug diffuses into the intrathecal space and acts in the opioid receptors in the spinal column. And in supraspinal effect, they are absorbed into the systemic action and they follow the systemic mode of action. So the intrathecal opioids, they act on the mu receptors in the substantia gelatinosa of the spinal cord. And epidural opioids have two different routes of action. One is either they diffuse and cross across the dura and act upon the mu receptors, and they are taken up by the epidural venous plexuses and also act in the systemic route. The intrathecal dose is 5 to 10 times lesser than the epidural opioids because they act directly on the mu receptors in the substantia gelatinosa of the spinal cord. So the intrathecal opioids, they potentially act as ligands on the opioid receptors in 3 different areas to produce analgesia. They either have a direct access to the dorsal horn of the spinal cord, that is the main site of action, or they are transported supraspinally by the bulk CSF flow. As the CSF circulates, they are transported supraspinally by the bulk CSF flow, where they modulate the descending inhibitory pain pathways. And a small amount also diffuses into the epidural space with subsequent systemic absorption, resulting in a centrally mediated analgesia, which contributes to a very minor effect of the intrathecal opioids. And coming on to the epidural opioids, after epidural administration, variable quantities depending upon whether the opioid used is hydrophilic or lipophilic, it will diffuse across the dura and the arachnoid matter into the subarachnoid space to bind to the opioid receptors in the dorsal horn of the spinal cord. So this depends mainly on the lipid solubility of the opioid used. And also, as said earlier, the epidural venous plexuses have a role in elevating the plasma concentration of the epidural opioids. Now, coming on to the pharmacodynamics of the neuraxial opioids. The bioavailability of the opioids in the intrathecal and the epidural compartments is determined primarily by the drug's hydrophobicity or lipophilicity. The lipophilic opioids, they rapidly diffuse into the neuronal tissues and they bind to the opioid receptors, and thereby it causes a rapid onset of action. So this action is mainly for the lipophilic opioids like fentanyl. So this also causes diffusion into the non-neuronal tissues like myelin and the epidural fat, and redistribution into the non-neuronal tissues cause the termination of action of the lipophilic opioids. Whereas the hydrophilic opioids like morphine, it stays in the CSF for a longer time, and there is a more rostral spread above the injection site in the case of hydrophilic opioids. So depending upon the property of the lipophilic and the hydrophilic opioids, respiratory depression is noticed very early in the lipophilic opioids like fentanyl, whereas in hydrophilic opioids, the respiratory depression occurs very late. So now coming on to the bioavailability of the neuraxial opioids. Neuraxial bioavailability. What is neuraxial bioavailability is how long does the opioid remains in the CSF space or the site of action. So that is called as the neuraxial bioavailability. This is inversely proportional to the lipid solubility of the drugs. So lipophilic opioids like fentanyl have a lesser bioavailability and they stay for a shorter time in the neuraxis. Whereas hydrophilic opioids like morphine, they have a higher neuraxial bioavailability and they stay longer in the neuraxis. So comparing the fentanyl and the morphine, which are the most commonly used ones, the onset of fentanyl is very fast. The action onsets within 10 to 20 minutes, whereas it is very slow. It is about 1 hour in morphine, and the rostral spread is very minimal, and it remains in the site of injection in fentanyl, whereas it is significant in morphine, and supraspinal analgesia is very common in morphine. And the duration of action is very short in fentanyl, whereas it is long. It lasts up to 24 hours in morphine. That is why the time of respiratory depression in fentanyl will be very fast. So the patients needs to be monitored during the initial periods when we administer fentanyl, whereas for a patient who have received epidural or an intrathecal morphine, monitoring should be continued till late, up to 24 hours or even 48 hours in case of epidural morphine. So this explains the spinal selectivity of the common opioids. It is very high in morphine and diamorphine, and moderate in fentanyl and sufentanil, and low in alfentanil. So if you look at this picture, in the second picture, when you administer the drug in the epidural space at 0th hour, sufentanil, morphine, and fentanyl will remain in the epidural space when we administer the drug. Whereas at 4 to 6 hours in the intrathecal space, only fentanyl and morphine will remain. And after 24 hours or between 12 and 24 hours, if you see, morphine will remain in the medullary space because of the supraspinal spread or bulk CSF flow. So this gives a gist of the lipophilic and the hydrophilic opioids. Lipophilic opioids, the analgesia is limited and the duration in the neuraxial region is very short and primarily work via supraspinal effect once absorbed only systemically. So it is difficult for the drug to reach and remain sufficient concentrations at the site of action due to the sequestration in the epidural fat. This terminates the action of lipophilic opioids like fentanyl very short, and there is rapid plasma clearance from both epidural and the intrathecal spaces. Whereas in cases of hydrophilic opioids like morphine, it binds directly to the specific receptors in the dorsal horn, and the intrathecal concentration will remain longer for elevated for a long period, and it may cause delayed respiratory depression because of the rostral spread. So now coming on to the equipotent doses of the neuraxial opioids. So what is equipotent dose? How much dose of neuraxial opioid should be administered to achieve adequate analgesia in comparison with the IV dose? So that is what is called as the equipotent dose of the neuraxial opioids. So this is based on the consensus and expert opinion and depending upon a clinical practice. So this depends on the factors such as opioid tolerance, age, and comorbidities of the patient. Roughly, epidural opioid is about 1/10 of the IV dose and intrathecal dose is 1/100 of the IV dose. So now coming on to morphine, if we can administer 10 milligram of morphine intravenously, then we will administer 1 milligram of epidural morphine and 0.1 milligram of intrathecal morphine. Whereas for fentanyl, the intravenous dose is about 100 micrograms and epidural dose is 25 to 33 micrograms and the epidural dose is 33 to 25 micrograms and intrathecal dose is 6 to 10 micrograms. So this is a table which compiles everything. Morphine is a long-acting hydrophilic opioid and the intrathecal dose is 50 to 200 micrograms and the duration of action is 8 to 12 hours and the epidural dose is 1 to 3 milligrams. And the duration of action is around 8 hours and it causes late respiratory depression and pruritus. Fentanyl, it is a short-acting lipophilic opioid and the intrathecal dose is 7.5 to 50 micrograms and the duration of action is less than 2 hours and epidural dose, it's a loading dose of 50 to 100 micrograms and maintenance dose is 1 to 2 micrograms. And duration of action is for the duration of infusion and the most common side effect is pruritus. Buprenorphine, this is a very commonly used partial opioid agonist and the intrathecal dose is 75 to 150 micrograms. This is a little higher dose which is got from the review of literature, but we use not more than 60 micrograms in the clinical practice. Duration of action is around 8 hours and the epidural dose is 150 to 300 micrograms. And same for the epidural dose, the duration of action is 8 to 10 hours. Most common side effect will be nausea and vomiting. Tramadol, it is a weak opioid agonist. The intrathecal dose is 10 to 50 micrograms, but it is very rarely used as an intrathecal dose, whereas for epidural dose, it is 1 to 2 milligrams per kg or 50 milligrams. The duration of action is around 5 to 7 hours. So when we administer tramadol, it is always advisable to administer ondansetron to prevent post-operative nausea vomiting. So if you look at this chart, fentanyl, the epidural dose is not given as a single dose. It is a loading dose of 50 to 100 micrograms because the duration of action will be lasting for only 2 to 4 hours, which is not very useful as a post-operative analgesic. So if you want to maintain fentanyl as a post-operative analgesic, you should add it in an infusion and maintain it at a dose of 1 to 2 micrograms. And the monitoring should continue for the duration of the infusion. So what are the complications of intrathecal opioids? So respiratory depression is the most common and dreaded complication of the intrathecal opioid. It occurs in about 7% of the patients. The presentation may be varied. Respiratory rate or tidal volume may decrease. And some patients may have hypoxia without alteration in respiratory rate or the tidal volume. So risk factors are extremes are age, concomitant opioid administration in alternate routes, and So it is better to avoid concomitant opioids if we are giving epidural or intrathecal opioid. Monitoring and supplemental oxygen should always be available when intrathecal opioids are administered. The second most common complication is pruritus, which occurs in about 5 to 37% of the patients. And ondansetron, it's a sedative, other sedative antihistamines may be used to prevent pruritus. Sometimes it is so annoying that it may require reversal with naloxone in severe cases. Urinary retention and nausea, vomiting are other common symptoms which may be treated accordingly. So now coming on to the newer mode of delivery of morphine, which is called as EREM, extended release epidural morphine. So this is a liposomal based preparation, liposomal based extended release epidural morphine, where the epidural, where the morphine is deposited in the epidural space, and it peaks in the CSF concentration at 3 hours, and the duration of action is at 48 hours. So here, the points to remember in epidural extended release morphine is, it must be injected as a preemptive analgesia prior to the starting of surgery, so that the peak action, the onset of action is when there is a skin incision. And in cases of cesarean section or for labor analgesia, the EREM must be injected only after the baby delivery, because we will not know when the baby is delivered. And when we administer liposomal morphine, no other epidural drug has to be given for 48 hours. And care must be taken not to inject this EREM through filter, as particles may be disrupted. So now coming on to the drug selection. So in case of opioid drugs, Neuraxial opioids are selected in preference to systemic opioids, because the respiratory depression caused by the Neuraxial opioids is much less when compared to the systemic opioids, and the dosage is also very less compared to the systemic opioids. And continuous epidural infusions can be continuous epidural opioids can be used in place of continuous patient controlled analgesia where opioids are used, or continuous epidural fentanyl is better than morphine if used as an infusion. And Neuraxial morphine is to be avoided in patients who are coming for daycare surgeries. So dose selection, lowest possible dose of Neuraxial opioids has to be administered. If needed, the patient's VAS score may be assessed and topped up with the additional opioids or local anesthetics. And concomitant administration of systemic opioids or other sedative premedications or sedative drugs has to be avoided. If at all they have to be used, patients has to be kept in the high dependency unit with the availability of supplemental oxygen. If hydrophilic opioids are used, monitoring should be continued at least for 24 hours. And if continuous fentanyl or remifentanil are used, then monitoring should be considered for the entire period of infusion. And management of respiratory depression. So coming on to the most common and dreaded side effect of opioid, which is the respiratory depression. There is a dose-dependent depression in the ventilatory drive, that is reduction in the minute ventilation and increase in the partial pressure of the end-tidal carbon dioxide can be noted in patients who are vulnerable to the opioid administration. So these patients are reversed with naloxone 3 to 4 milligrams per kg per hour, or ampakines can be used, and the newer repinotan, which is a selective serotonin 1A receptor antagonist, can be receptor agonist can be used. So once a patient is identified with a respiratory depression, what is the treatment the patient should receive? Supplemental oxygen should always be available in patients receiving Neuraxial opioids in the postoperative ward. And in patients who have an altered level of consciousness or respiratory depression or hypoxemia, supplemental oxygen should be continued until the patient is alert and no respiratory depression or hypoxemia is evident by the ABG sampling. Reversal agent should be available for administration to all patients exhibiting significant respiratory depression. In presence of severe respiratory depression, appropriate resuscitation should be initiated. Non-invasive positive pressure ventilation may be considered for improving the ventilatory status. If there is a frequent or severe airway obstruction or hypoxemia during the postoperative period, non-invasive or sometimes invasive positive pressure ventilation can be initiated to treat the respiratory depression. Now coming on to the next group of drugs, very commonly used group of drugs are the alpha-2 agonists. So clonidine and dexmedetomidine fall under this group. These are selective imidazoline derivatives which work in great combination as with the local anesthetics in the neuraxial blockade. So the alpha-2 selectivity of clonidine is 220:1, and for dexmed it is 1620:1. The alpha-2 is to alpha-1 selectivity. So these alpha-2 agonists, they bind to the postsynaptic alpha-2 receptors in the dorsal horn of the spinal cord, and thereby inhibiting the presynaptic release of the excitatory neurotransmitters and preventing the nociceptive transmission. So there may be a significant fall in BP because of the reduced preganglionic sympathetic outflow at the spinal dorsal horn. The sedative effect of these alpha-2 agonists are mediated by the supraspinal effect. Coming on to clonidine. So there is a definite increase in the duration of blockade and it prolongs the postoperative analgesia also. So in a study conducted by Pankaj Kundra, the Neuraxial clonidine triples the duration of spinal anesthesia. It triples the duration of spinal anesthesia, that is this surgical anesthesia, by 5.3 hours versus 1.8 hours in patients receiving plain bupivacaine who undergo hip surgery, and the caudal clonidine prolong the time to require first rescue analgesia by 6 hours in anorectal surgeries. The intrathecal and the epidural doses of clonidine are 15 to 50 micrograms, that is 0.5 to 1 microgram per kg, and doses greater than 30 micrograms may cause bradycardia and hypotension. So this clonidine is not preferred for continuous epidural infusion because of the incidence of bradycardia and hypotension. And in elderly patients and very young patients, that is extremes or age, caution should be noticed. So clonidine is used for hypotensive analgesia and bloodless surgical field also. So going on to the literature. So this is a study where 75 patients are enrolled into the study, divided into 25 each group. One group received 15 micrograms of clonidine and the other group received 30 micrograms of clonidine against a control group. So here they have concluded that 30 micrograms of clonidine was associated with more incidence and duration of hypotension than 15 micrograms. However, both the groups have a better sensory and motor blockade for inguinal hernia wrapping. So this is another study where the clonidine is used as an adjuvant to hyperbaric bupivacaine for spinal anesthesia in elderly patients undergoing lower limb orthopedic surgeries. Here too, they have concluded that clonidine in doses of 30 micrograms facilitated the ascent of sensory level to higher than expected dermatomes for a longer period, and the request to first rescue analgesia is also longer. So now coming on to dexmedetomidine, which is a selective alpha-2 agonist. So this has the advantage of prolonging the sensory blockade without prolonging the motor blockade. So dexmedetomidine has a greater inhibitory effect on the A delta and the C fibers relative to the motor neurons, and this has a neuroprotective effect with reduced perineural inflammation. The intrathecal dose of dexmedetomidine is 5 micrograms, and there is an increase in duration of analgesia by at least 7 hours. The common side effects of dexmedetomidine usage are bradycardia, hypotension, and sedation. Sometimes resistant bradycardia may occur in elderly patients, which may require treatment with atropine. So these are two studies where dexmedetomidine is used as an intrathecal adjuvant to bupivacaine. So they have concluded, one study has given that 10 micrograms of dexmedetomidine can be used as an adjuvant to local anesthetic. And another study has told that 5 micrograms or 10 micrograms can be used as an adjuvant to local anesthetic to prolong the postoperative analgesia. So this is another study where they have done the study on the intrathecal dexmedetomidine for parturients undergoing cesarean section. Here also they have used a minimal dose, that is 5 microgram to levobupivacaine. So they have concluded that dexmedetomidine is a potent local anesthetic adjuvant. An intrathecal combination of 5 micrograms of dexmedetomidine can exhibit a facilitated drop and improve the parturient's recovery quality. So this article defines the use of epidural dexmedetomidine for labor analgesics. So here also, epidural dexmedetomidine has a potential to offer a better analgesic effect than placebo and can be comfortably used in the laboring parturients. So now coming on to the other group of drug, which is the NMDA receptor antagonist, which is ketamine and magnesium. The NMDA receptors have a role in pain modulation, and it contributes to the wind-up phenomena, central sensitization and peripheral sensitization. So blockade of these NMDA receptors in the spinal column can result in prolongation of the analgesic property. So coming on to the ketamine, ketamine is a non-competitive NMDA receptor antagonist, and it can be used as an adjuvant to LA, local anesthetic, for postoperative analgesia and to reduce the opioid-induced hyperalgesia. There are two isomers of ketamine, S plus and R minus isomers, and S plus is a preservative-free ketamine and can be used in the neuraxial blockade. This causes non-competitive blockade of the NMDA ionophore, and the intrathecal dose is 25 milligrams and epidural dose is 0.5 to 1 milligrams per kg. Coming on to magnesium. Magnesium is a non-competitive NMDA receptor antagonist and calcium receptor antagonist. This potentiates the local anesthetic action and reduces the requirement. Magnesium also decreases the peripheral nerve excitability. Intrathecal administration has been shown to suppress the nociceptive impulses in the neuropathic pain and potentiates opioid anti-nociception in animal studies. The dose of intrathecal magnesium is 50 to 100 milligrams in the concentration of 50%. And epidural magnesium can be used as 50 to 100 milligrams in labor analgesia. For postoperative analgesia, it can be used up to 500 milligrams, and this prolongs the postoperative motor, sensory, and the analgesic duration also. Coming on to dexamethasone. Dexamethasone is the commonly used corticosteroid, and the property of dexamethasone when used in the intrathecal or the epidural dose is very different from the intrinsic anti-inflammatory mechanism. The local action on the nerve fibers and systemic effect is exerted by the epidural or the intrathecal dexamethasone. It potentiates both the analgesic property and the anti-inflammatory property at the local site of injection. It can be used in the doses of 8 milligram or 4 milligram, but doses greater than 8 milligram can cause hyperglycemia in diabetic patients. Midazolam is another short-acting benzodiazepine which acts on the GABA-A receptors, and Neuraxial midazolam acts on the benzodiazepine receptors on the gray matter of the spinal cord. The highest concentration of the GABA-A receptors are found in the lamina 2 of the dorsal horn. The analgesic action of midazolam is mediated by the spinal suppression of the sensory functions, and its anti-nociceptive effect is mediated by the GABAergic and the opioid receptor mechanism. Midazolam can be used in the doses of 1 to 2 milligrams. Neostigmine is another muscarinic receptor agonist. It increases the endogenous acetylcholine at nerve terminals, and it produces spinal analgesia by inhibition of the endogenous neurotransmitter acetylcholine destruction at the dorsal horn of the spinal cord, substantia gelatinosa at lamina 3 and lamina 5. It is used in the intrathecal dose of 5 to 10 micrograms and epidural dose varying from 1 to 10 micrograms. Most common side effect will be postoperative nausea, vomiting. Bradycardia can occur. Agitation and restlessness are other side effects. Doses greater than 50 to 150 micrograms are associated with the postoperative nausea and vomiting. Other vasoactive agents are also tried to be used as an adjuvant to local anesthetic, but these are commonly discontinued because of the transient neurological symptoms and the spinal cord ischemia. So epinephrine, the substantia gelatinosa of the spinal column, houses the alpha-2 adrenoreceptors, wherein the epinephrine acts by its direct action on these receptors and mediates the anti-nociceptive properties. So there is a presynaptic inhibition of the transmitter release from the A delta and C fibers. The vasoconstrictor property limit the usage of epinephrine in the neuraxis. They were used in the dose of 0.2 to 0.3 milligrams. There is a risk of spinal cord ischemia. Phenylephrine also has a similar action to epinephrine, and the dose was around 2 to 5 milligram. Phenylephrine was also discontinued because of the transient neurological symptoms. Soda bicarb. Soda bicarb is another common adjuvant, though we have not used it in the central neuraxial blockade. It is very commonly used as an adjuvant in the peripheral neuraxial blockade because to alkalinize the local anesthetic, which improves the quality of blockade by increasing the pK of the local anesthetic and thereby increasing the speed of onset. This influences adding soda bicarbonate influences the proportioning coefficient of local anesthetic between the aqueous solution and the biological membrane, and thereby increasing the proportion of the drug which is able to cross the lipid membrane of the nerve cells. The alkanase solution should be prepared just before it is used because it precipitates with time at room temperature. So the most commonly used preparation is 1 ml of 8.4% of soda bicarb to 10 ml of lignocaine. Ropivacaine can also be alkalinized when the volume of bicarbonate 8.5% is added to ropivacaine is greater than 0.1 ml per 20 ml of ropivacaine. Upon concluding, we must understand the pharmacology and the pharmacodynamics of the additives which we add in the neuraxial space. It must be dependent on the duration of the surgery, and we must understand the onset of the additives added and the duration of action for prolonging the analgesia. Anticipating the problems and appropriate monitoring of the drugs according to the additives added to the neuraxial space will improve the quality of anesthesia. Thank you.